Okay, so thanks everyone for being here and being online. We have two speakers today who are relatively new additions to CORE, and they're going to tell us about machine learning for better pediatric care. Kind of two different perspectives, it sounds like, emergency medicine and endocrinology. So I'm very much intrigued. Esli, Angeliki, take it away.
Thanks so much, Ben. Thank you all for being here, and to those on Zoom. It's a pleasure to be here this afternoon. Yes, Angeliki and I have no conflict of interest to disclose, and we do share an interest on AI. And although the topic here is use cases in pediatric emergency and endocrinology, you'll see that there's many other domains where it can be applicable in pediatric care. We share an office, so figured let's talk about those two fields. So the presentation outline, we'll start with a primer on AI, just to put everyone up to speed with some of the terms we'll be using, and then talk about some specific use cases in our respective programs, and also some potential projects moving forward. Then we can't talk about AI and healthcare and responsible innovation without talking about patient and public engagement. So that'll be a part of the presentation. And we'll finish by conceptualizing what responsible innovation in health means in this domain. So you're all here, so it feels like I'm preaching to the choir. I mean, you're certainly interested by AI and health, but so is CFAR, so is CIHR and FRQ-S. This is no news. In 2020, in a report on AI for health, CFAR highlighted that even from a competitive advantage point of view, it'd be strategic for Canada to focus in specific fields in AI as opposed to trying to be a leader in all possible domains of application. And health seemed to be one of the very strategic fields to invest in. Without further ado, I'll pass it on to Angeliki, and the mic as well. It's high-tech AI stuff.
Yeah, exactly. Yeah.
Here it is.
Perfect. Thank you so much. So if you don't mind, I'm going to sit because I'm here. Just because someone is complaining. Perfect. So enabling precision medicine. So precision medicine, and thank you, Esli, thank you all for being here today. So hope we're gonna keep you entertained today. So precision medicine is often described as the provision of providing the right treatment for the right patient at the right time. And it focuses on integrating data from multiple different resources in order to improve diagnosis and also the micro. Yeah, that's true. Yeah. I'm sorry. So many years, 3 years into Zoom, it's very different to be in person. So precision medicine focuses on integrating data from multiple different resources in order to improve diagnosis and treatment outcomes. So here we see a comparison between, go back. A comparison between current approaches in medicine and future approaches using precision medicine methodologies. So currently what we're doing in many diseases in medicine is that we're using the notion of one treatment fits all. So we have all these patients who are diagnosed with the same disease. They all are, though, very different in many aspects of this disease. They're all being given the same treatment. So some of them will respond, some of them will have no effect, some of them may even have adverse events. So in a more ideal situation, what would have happened, and actually this is what's happening in fields like oncology, where they're using precision medicine approaches, is that all these patients, they will be having detailed genetic testing, immune profiling, tissue analysis, and then the therapy that is being given to them is based on each patient's unique profile. So that increases the chances of the treatment being successful. So artificial intelligence and machine learning in healthcare research. So this is not something new. AI has been around for a few decades now. It has been around actually since the 1950s. And it is defined as the science of making intelligent machines, like devices that can mimic cognitive functions. So back then in the 50s, the computers lacked a key prerequisite for intelligence. They couldn't store commands. They could execute the commands that they were being asked to do, but they couldn't store these commands, meaning that they couldn't learn from the experience that they had. So this changed in the 1980s when machine learning was introduced. So with machine learning, we describe algorithms that improve as they are exposed to more data. And finally, in 2020, we have the introduction of deep learning that really popularized the field of machine learning and AI, and which is now integral in many software devices and applications that we're using in our daily lives. So in this graph, we can see that there has been an exponential increase in the number of publications that we see in medical AI studies by year. So there's definitely like machine learning is gaining a momentum, and this is facilitated by the fact that computers are now doing a much better job in their computational analysis, and also by the fact that nowadays digital data are readily available in electronic health record systems. So interestingly, when we break these studies down by subspecialty, we're going to see fields like my field in endocrinology that are still at the bottom of the list. And it's no surprise that we see fields like radiology and pathology that they're using more like a popular, like vision recognition systems to be like heavy in AI research. So let's go over some definitions. This is from the most recent report of FDI on artificial intelligence and machine learning, in software as a medical device. So artificial intelligence is defined as the science of making intelligent machines. Machine learning is under the umbrella of artificial intelligence and is described as the technique that can be used to design and train software algorithms that are going to learn from data and they're going to act on data. So despite the fact that AI has been around for a few decades now, it's a relatively new field in healthcare research. Nearly every other industry uses data on previous actions and previous outcomes to enable smarter ongoing choices. So this is the notion that we're trying to bring into healthcare research. So AI applications in healthcare can be used in a variety of different like medical fields, from health services management, which really provide like business solutions, how to improve clinical workflow, or how, for example, like order like supplies for a hospital unit based totally on prediction algorithms. To patient data and diagnostics, predictive medicine, and clinical decision-making. And this is the area that we're going to focus more on our presentation. Here, we leverage the ability of AI to analyze a vast amount of digital data, and through such analysis, to come up with meaningful like clinical relationships. So in the next few slides, we're going to go over like the main types of machine learning algorithms. We're not going to go into technical details. That's beyond the scope of this presentation. But it will be important to, like, for us as clinicians, to gain some familiarity with the terminology that's being used in machine learning, as it is anticipated that we'll be growingly relying on these approaches to provide high quality of patient care. So there are three main different machine learning algorithms. So we have supervised learning, unsupervised learning, and reinforcement learning. So in supervised learning, we have the teacher or the developer of the machine learning algorithm who knows what he wants to teach to the child, and he defines what the expected answer should be. And then the child learns to perform the task. So there is a predefined outcome. And in medicine, like this could be represented by, for example, training a model to relate patients' characteristics like the BMI or the social status or the smoking status to a certain outcome, like developing diabetes, for example, after 5 years. In unsupervised learning, what happens is that the teacher does not define what the child needs to learn. So there is no predefined outcome, but rather what happens is that the teacher is going to observe what the child is doing, and then he's going to draw conclusions based on what the model had done. So here there is no predefined outcome. So the unsupervised learning approaches are really exploratory approaches. So you're trying to identify hidden data, hidden clusters or groups within your data set. And this is another like visual illustration of unsupervised algorithms. So you have the raw data that are represented by the different shapes that are presented to the algorithm, and then the algorithm is going to group this data together based on similar data points. In reinforcement learning, what happens is the teacher here again knows what he wants to teach to the child, but he's not going to define step by step how the child is going to learn. But rather, at the end of the task, after the task is completed, the teacher is going to give feedback to the child based on the mistakes that it made, and that's giving the opportunity to the child to learn from the experiences that he had. And finally, in deep learning, you analyze like very complex data sets from videos or from images or from unstructured data points. There are many like different layers of processing, and this really imitates how the human brain is working. So now let's take a closer look of how like a machine learning model is developed and validated. So we start by splitting our data set into two segments. We have the testing set and we have the training set. So the testing set is like the data points that we're keeping aside in order to ensure that the predictions that we're going to develop will be validated beyond our training set. So the remaining of the data here are further split into two sets: the training set and the validation set. This is what we're actually going to use in order to build our machine learning model. And then this is going to be presented to the validation set to further tune the hyperparameters, and the final model is going to be applied to the testing set. And we're going to compare the predictions that the model is making against the known outcomes of the testing set. And this is how we're going to evaluate how well like the model is doing, how accurate the predictions are. So my last slide before talking specifically about type 1 diabetes and our use cases in endocrinology and in pediatric emergency medicine, it's a comparison between like machine learning and statistics. And that's at least a question that I had when I was starting my journey in the world of AI. What is the added value, or what is the advantages or disadvantages of machine learning versus conventional statistical approaches? So, and it's true that there are many commonalities between the two approaches. And a way to see this is by considering what is the goal of each method. So in statistics, what you're trying to do is to understand causality. You're trying to understand inference. You're trying to understand what is the relationship between the variables and the outcome. While in machine learning, your goal is to make accurate predictions without necessarily understanding how the variables are connected to each other. So first, the added value of machine learning here is that you can use it in conditions where the variables are not connected through like linear relationships. So, for example, when you're studying a new SNP in a new gene, a SNP is like a difference in the DNA sequence. So you don't know from before whether this new SNP is going to increase or decrease, for example, your chance of developing lung cancer. Oops. Sorry for that. And also, like, it's useful in cases where you have many different variables that can all have an effect at the total outcome, but with each variable having a small individual effect. And this is true in diseases like type 1 diabetes, where, for example, we know there are like more than 70 susceptibility genetic loci, and each of these loci, they can have a small individual effect on the total outcome. Please, Dan.
Questions now at the end.
Please, yeah.
I just have a bit of a problem with this separation between traditional research and machine learning research. For one thing, it really dumbs down AI, because from an academic viewpoint, there's no hypothesis, or worse, it does not matter. And I understand that this all comes from a very good paper, but I think that it's true that you don't have, it's not all inferential, but in fact, there's always a research question. And I think that if we want credibility for AI research, I would not think of it any different than starting with a research question. The research question may not be, is this drug better or something like that, but it would be, can we treat these patients better using these data sets or those things? Because I find it really falls into what engineers and AI computer scientists do, which is which I find terrible, which is that it goes so much against our brain as clinicians or clinical researchers, which is that, well, we'll just take a data set and we'll just throw a bunch of models at it. And if one model picks up a high AUC, then eureka.
Well, no, like the point of that is to say that like in machine learning, you can have like a hypothesis-free design, right? And it's really a data-driven research. While like in statistics, you need to formulate the hypothesis in the beginning, and then you test this hypothesis, you validate this hypothesis using statistical analysis. So really, like I agree with you, like there are many commonalities between the two, and like it's not very easy to distinguish like whether this is like statistics versus machine learning. But definitely, like I agree with you, like machine learning, it's not a real like hypothesis free. Like it's really that you are trying to focus more on what is whether the prediction is accurate, rather on how you ended up with that outcome. So it's really like seeing these two approaches from a different perspective. What is the goal of its method? Yeah, no, but I agree with you. Like, it's not, that's a very simplistic like approach of, yeah, exactly. And I think they were just trying, like to make it like clear of how this works. Perfect. So moving forward, so I'm going to talk about type 1 diabetes. That's my clinical area of expertise. And then Esli is going to take over and is going to give some case illustrations in emergency medicine. So a brief introduction on type 1 diabetes. This is a chronic disease that you cannot produce any insulin because the cells that would normally produce insulin in your pancreas are destroyed due to an autoimmune process. And the result of this is that you cannot use the glucose as a source of energy to support your vital organs. And so you're not having insulin, not only you cannot support your vital organs, but now you also have to deal with all the effects of accumulating glucose into your bloodstream. So these patients need continuous insulin treatment. In order to apply this precision medicine approach that we discussed earlier into type 1 diabetes, we need to understand a little bit more about the heterogeneity of the disease. And this is not something new in the literature of type 1 diabetes. We know that there are different traits like BMI, age at diagnosis, specific genetic like haplotypes or distinct immune responses, even what is the first autoantibody that you're going to detect when someone is diagnosed. All these factors affect how well you're going to do in controlling your diabetes in the years to come. And of course, in this acquisition, you need to add social determinants of health and self-management of diabetes. So this graph is from a recent paper on adult patients with type 2 diabetes, where disease subtypes were discussed. So they were defined based on a series of clinical traits. But you can have patients that have traits that belong to different subtypes. So that's the concept of endotypes that is now popular in the field of diabetes research. So you have like a distinct pathobiological mechanism that defines the symptomatology that each of these like patient subgroups are going to develop, and also the risk of complications and their like clinical outcomes. So a project that I'm currently involved in is in defining like type 1 diabetes subgroups using machine learning approaches. So we're building a type 1 diabetes biobank with 1,000 patients from 10 participating clinics across Canada, pediatric diabetes clinics. So we're analyzing clinical data, labs, immune markers, and genetic markers using hierarchical clustering and deep generative models in order to identify disease subtypes. And hopefully I will have like some results to share with you soon. So a tool that I'm using in order to collect high quality standardized data on how well the diabetes is controlled is a novel digital platform that's called TIDE, Timely Interventions for Diabetes Excellence. And Esli is going to tell us a little bit more about this platform. This was developed by our collaborators at Stanford, and Esli was involved in that during his time at Stanford. So this is a digital platform that uses an algorithmic approach in order to assess patient data on continuous glucose monitoring. So these continuous glucose monitors, or as we call them, CGMs, are now part of the standard of care for diabetes management. So you have this little machine that is on you, and it measures your blood sugar every 5 minutes. And you need to change this once every 2 weeks, as compared to what we were doing before this technology was widely available. We would use a glucometer, so the patient would have to poke their finger like 4 or 5 times per day and would get like a blood sugar measurement. So now we're moving from having like 4 or 5 measurements of blood sugars per day to having more than like 200 measurements per day. So a challenge is how you're going to make sense of this vast amount of digital data. So in that context, that platform was developed. And I'm using this in my research project, and we're going to hear from Esli, who was involved in the development of that project while he was at Stanford.
Thanks, Angeliki. Awesome. Thanks for the background information. All right. So continuing with this TIDE platform, there's a couple of important learning points for me when I joined the team at Stanford with David Shanker, Ramesh Johari, who developed this tool along with their pediatric endocrinology. I'm just going to grab the clicker. So one of the important points is you don't need the fanciest technology. You don't need the fanciest algorithm. At the end of the day, the algorithm we're talking about here is not deep learning. It's a simple rule-based algorithm. They tested different algorithms and chose this one because it was the most interpretable and also really served the clinical need, which was to make sense of that huge amount of data and help clinicians save time reviewing all those CGM metrics from the patients, because they had a fixed number of diabetes educators who were in charge of reviewing the data and couldn't increase the capacity of the clinic infinitely because of their constrained human resources. But then this tool came along, and what it did in terms of innovation is that allowed them to have a population view of their clinic. So the some patients that had CGM data available, and every week the tool would essentially summarize the patients that needed a frequent touch point. Not all patients will need to be seen more frequently than the usual every 3 month endo appointment, but some actually need to have a touch point, a message, a call. Hey, your diabetes seems to be out of whack. You seem to be having a lot of lows. What's going on? Can we look into that? And most of the time, those are simple interventions. You know much better than I, but I unfortunately end up seeing these patients in the emergency room in ketoacidosis because they've been lost to follow up. They're sick. They haven't managed their sugar and their insulin properly, and they come into the emergency room in a very, very dangerous state, potentially lethal. So what TIDE enables is this population view, but at the same time, it allows individualized care. It really presents within the same dashboard, you have those top 10 patients that need a touch point right now. You click and then you have their data. What providers were struggling with before is with all the softwares available, different companies out there, they had to log into different platforms for their 100-some patients in their clinic. So that translated into a lot of time loss. So not only did this allow clinicians to help their patients improve clinical outcomes, but also led to up to 60% reduction in the average time needed per patient to review the data. And that's from the diabetes educators. And in turn, we have clinical improvements here, but we also have operational improvements. The clinic becomes more efficient, increases capacity, and is able to offer remote review for more patients in their clinic. So it's a win-win. Now, switching gears a little bit to the emergency room, talking a bit about conversational agents. So that includes chatbots and very rule-based agents, commonly known as chatbots. We'll probably all use them and probably all hated them when we're trying to get a hold of our bank rep or cell phone rep. I usually go help until I get the person on the phone. But the technology has evolved a lot. So that's what's exciting at this time. What's the context? What's the need? Speaking to families, seeing families in a clinical context on a daily basis, families call 811. So for those who don't know, it's a phone line aimed to either reassure or tell you should actually see a doctor or help you navigate the primary care network. First of all, during the triple pandemic we had in last fall, so RSV, influenza, COVID, and pediatrics, that phone line was overwhelmed, just like any other primary care access point. Families would be on the phone for 3 hours to call 811 to be able to reach someone, and then from one person to the other, the instructions were not very standardized. Although they have some rule-based approach to pediatric care, there's still a lot of variability in the level of expertise you get on the other end of the line. So oftentimes families call to get reassured, but because it's a younger patient, because there's less pediatric familiarity in the professionals on the phone, they're often asked to go to the emergency just in case. So actually a lot of families come wait hours and hours in the emergency room because they were told to come in and feel bad to just stay at home. So there's also limited specialized pediatric knowledge. The goal of a tool like this one is to really expand that knowledge, make it more accessible to frontline providers. And there's also spread of misinformation, disinformation. Excellent resources are available on the web, but also some pretty hurtful information. And in terms of vaccine hesitancy, that's a main topic that has significant public health ramifications, but you can think of that into many other fields. And also it's co-occurring within the expansion of telemedicine. So all of a sudden you have the possibility of seeing a provider through audiovisual means from home, and that can really complement the family experience. When users interact with a chatbot, typically they want an interactive conversation. They want some relation skills on the end of the machine. They want to feel personal, to have some empathy, perhaps, especially in the healthcare setting. But frequent issues are poor understanding, again, referring back to the experience we may have with banks, with phone companies. So voice recognition accuracy, error management of word inputs. And so that really can stifle the innovation in this field. But there's been some technical progress along the years. Angeliki was talking about the early steps into artificial intelligence development in the 50s with the Turing test, which is the one of the gold standard tests to really test whether a system fits into this general artificial intelligence. Can it really mimic or act like a human would? And so starting from the 50s, there's been longitudinal developments into conversational agents and chatbots more specifically. Most of them early on were very rules-based. So if the person says A, you respond B. If they say C, you respond D, and so on. In the late 2018, 2019, BERTs, the bidirectional transformer models, really transformed, no pun intended, the field of natural language processing. They're able now to look at language streams from both directions. So it's better able to contextualize, to understand complicated language, to translate much better, and the performance really exponentially increased from there. Most recently, you've probably all heard about generative pre-training, GPT, OpenAI, large language models. So these are trained, essentially it's brute force. It's millions and millions and trillions of data that allows them to become better and better. Taking the example of GPT, we started with 3 a few months ago, 3.5, 4 now. And already from 3 to 3.5 to 4, there's been incremental improvements in performance. So we can stipulate that that could actually be one of the first forms of general artificial intelligence in the future. Not there yet, but it's a good candidate to reach that. How do we place that, though, in healthcare? One of the issues with these models, you may have heard in the media or in medical journals, there's more and more publications in that, misinformation or actually making false claims and seeming confident. It's that confident inaccuracy that these models are essentially trained to do. We're currently in the process of, we have a paper reviewed that looked at the accuracy of sources, medical sources that ChatGPT, the GPT-3 provided to medical questions, and a high proportion, I'll share that with you when it's published, but a high proportion was confabulated. So it looked like the right source, but when you put everything together, it was an author that had published in the right field. The journal was right. It's a nice journal, right type of methodology. But when you put everything together, you go on PubMed, it does not exist. So clearly, you don't want that in healthcare. The stakes are too high. But how can we use it in pediatric emergency care, given the context I explained earlier? If a patient with something very common, 2 out of 10 kids have asthma or will have asthma at some point in their lives, or fever, obviously very, very common in the fall and winter. We have here Dan Panaro and the children's journey. So his lab at the Commissaire Lab is developing the children's journey, which aims to transform the interaction between providers and families, improve communication through a digital innovation. That could really be a nice platform to integrate eventually a conversational agent and a chatbot to improve knowledge mobilization between families and providers. So now think about the family whose child has some difficulty breathing or has some fever, is having a hard time logging or connecting with 811, logs in and asks a few questions about their child's condition. This is a snapshot of the children's journey currently in development, but just to get a feel of what we're dealing with, you have specific personalized journeys for asthma, for gastroenteritis, for fever. And what's a big advantage here is that we'll be able to curate that content. The knowledge base of the chatbot will be very strictly curated by an interdisciplinary team that really is able to update it frequently as new knowledge emerges, but that limits that spread of disinformation because it will be tightly curated. But on the front end, you'd have those very performing algorithms that are able to better and better understand human language and have that feeling of humanness. So it's really combining both worlds here. You can imagine a conversation that goes like this: how can I lower my child's fever? And then, the chatbot could say, well, that's actually usually not necessary as long as the child doesn't present some of these symptoms. Is her nose congested? Yes, it's congested. Sharing some helpful info here again, trying to combat that spread of misinformation online where you're not sure if the information you're accessing on Google, is it actually validated? Is it a trustworthy source, especially if you have no close contact in the healthcare profession? A lot of times, perhaps those of us who also have a clinical practice might get calls from family just to help navigate the system. So a very preliminary role for a tool like this would be exactly that, especially for families who don't have those contacts. So this is the front end. This is where ChatGPT type models, large language models, would be very useful to be able to do that natural language understanding. This is the operational process of that ideal chatbot I'm talking about, which is inspired from Marvin. Some of you may have heard about Marvin. It's a chatbot that Bertrand Leboucher and his team, Yann Chauma as well, developed. So here from Core. It's a chatbot that's been deployed here at McGill among adults who live with HIV to help them with medication self-management. Again, think of a constrained topic. We have a pharmacist on the team. We have patients on the team who help develop this. And the knowledge base is very curated so that the information the chatbot is eventually able to output is trustworthy. But on the receiving end, on that patient and family-facing interface, you really have that interactiveness and that improved understanding, contextualized understanding that large language models have allowed us to achieve. And so the infrastructure of the chatbot I'm talking about starts with that natural language understanding. So there's machine learning and NLP algorithms there that are able to understand and contextualize what the family is saying, and that's based on pre-training. So the more formulations of how do I manage my child's fever, the more formulations you have of that question, the better the algorithm will be at identifying, okay, with 85% probability, this family is talking about fever and they're trying to understand how to manage it, or they're concerned that it's meningitis. So how do we deal with that? We need a lot of training data. That's where the training data sets come in. And that's where an innovative and responsible way of using large language models can actually assist us. Think about going on ChatGPT. I'm using ChatGPT because it's on everyone's minds these days, but it can be any large language model. And you ask it, give me 100 formulation to this question. What do I do with my child's fever? All of a sudden that can actually, it's all fed from internet data, and it helps you feed your training data set that you've actually already started building with patient partners, with family partners upstream, but now you have this capacity to very efficiently improve your training data set. Of course, please. That's a great point. So conversational agents are not limited to chatting or to texting. It can definitely be voice recognition, could be different tools of communication. The one that Marvin focused on was a text-based. Because of the population that they were trying to serve, there's also a component of offering anonymous support that was timely 24/7. That was part of the strategy there. We're also thinking about a text-based chatbot, but certainly there's many other forms. With voice recognition, as Angeliki mentioned earlier, that's another big one that could be helpful in this case for the input. But of course, your training data set would have to reflect that choice, and you'd have to have significant changes in diversity in the voices and the questions that are asked to train this chatbot. So once you have the natural language understanding, then you move on to dialogue management. What are we talking about? What's the context of this conversation? Who are we dealing with? What's the patient population? And these modules constantly interact with the knowledge database. That's the part that's been tightly curated with a development team, which includes families, very important to have families upstream, and this type of development, clinician experts, software engineers. So it's really a multi-stakeholder interdisciplinary development to make sure that we get it right from the get-go, or actually are able to rapidly and iteratively improve the model. And eventually, once we've got that figured out, the model will select the best response. I think I understand where we're going with this. I go back and connect with our knowledge base. Our development team wants me to respond that, if the concern is fever, this is the output that should be giving out. And then you have the message output that you see on the left-hand side. Any questions?
All of those parts, you mentioned NLU, natural language understanding, but all of the ones on the side there, all that NLP.
Right. Yeah.
Because it's all about communicating with the database and putting it in words.
Yeah.
Use words.
Yeah. So in the dialogue management, there's a memorization policy that interacts with that knowledge database, and that's also based on NLP algorithms. But you also have a very strict rules-based policy. Again, referring back to the TIDE algorithm, where pretty simple algorithm, very interpretable, very explainable. So you don't have to have the fanciest algorithm every step of the way. You can really adapt it to your need. But absolutely, every step of the way, you'll have different algorithms, NLP algorithms involved. Now, we talked about patient and public engagement being key here. I like this phrase, lift every voice. Or try to, right? Try to. Of course, in a patient advisory council of 10, 12 patients, you won't be able to lift every voice, but you're attempting. There's going to be focus groups. There's going to be longitudinal public engagement initiatives to try and get this right. But there's a risk of exacerbating disparities, right? The term intervention-generated inequality, IGI, has been coined many years ago before this recent expansion of telemedicine. But what it refers to, this IGI, those are inequities that are a result of use of digital interventions, AI, with unintended consequences. So if it's really the better off, the people that are most wealthy, most educated, those that are least likely to suffer from the digital divide, that eventually end up having access to these technologies, will end up just exacerbating existing disparities. And that's a big concern in this field. So lifting every voice, or trying to at least, and getting better at over time, building partnerships with communities that could benefit from this technology, but are at risk of being excluded from lack of inclusivity and accessibility to the tool, is key. We've often seen technological development at fast pace, but no accompanying social innovation. A recent example was the COVID alert app. Lots of money put into the development. Mila wanted also to develop an AI-based algorithm that helped predict the probability that you're in contact with someone who had COVID. So the idea was very, very interesting to support the limitation of COVID propagation. But there was very limited effort to co-invest in all the other subsystems that are necessary for that innovation to be successful. At the end of the day, 2 years later, millions of dollars into development and some campaign. Who uses COVID alert? What was the impact here in Canada? Very limited. Some countries like UK perhaps had some benefits from it, but it remained very limited because there was no early engagement of stakeholders. We felt like there was a sense of urgency, which clearly was there. But unfortunately, when we fail to include stakeholders early on, we'll end up losing even more time. When the product is finished, it's not the right time to think about inclusive design and organizational system adaptations. How are we doing in terms of AI trials and prompts, patient-reported outcome measures? This is a recent study from the Lancet Digital Health that essentially shows that although over time, so the blue bar here on the stacked histogram shows trials that use some form of PREMS, or the visual analog scales in their methodology, we see that it's steadily been increasing. but it's still not perfect. And only 7% of AI trials in this period from 97 to 2022 used a PROM as their study endpoint, compared to other non-AI trials, which for which it was about a quarter. So 7% versus about 25%. So there's still a long way to go. And it matters because although we're talking about highly sophisticated, highly technical clinical care settings integrating these technologies, we have to remember who we're doing this for. It's really to improve care. It's really to make the life of, as you mentioned, Dan, earlier, did it make a difference in the child's or in the patient's life? That's really what matters at the end of the day. This is a framework developed by Carman and Pomé that eventually led to the Montreal model to frame patient engagement. The continuum of engagement from information being the lowest form of engagement. Here's what we're talking about. This is the chatbot, some infographics on it, consultation, collaboration, let's work together on developing it. And then the highest form is partnership. Let's be co-researchers. Let's be co-PIs on this study because your lived experience, your expertise as someone who either lives with disease or who cares for someone with a disease, who has a complementary view on this study would be really important. And you see the different levels where patient engagement can be crucial in healthcare. The one we're focusing here is research, but it can certainly inform clinical operations. It should certainly inform direct clinical care with the families we serve. And it can also help public policy shaping and organizational adaptations. So at the Children's, close to a quarter of families among about 200 families that we surveyed along with Dan and two students working on this project, 23% of families had some factor that put them at risk of the digital divide. So just highlighting how important it is to have diverse perspectives early on in these projects. We want to make sure that the chatbot we talked about, the TIDE program we were referring to, fits within the abilities, but also within the needs of those families as well. We don't want to leave them behind because those programs have shown clinical outcome improvements, which will probably keep getting better over time as we train models to get better. But we can't leave 23% of our families behind. It's important to include them in the development of these tools early on so that they're fully a part and partners into their deployment and development. Right, so the digital divide is multifactorial, right? It's essentially putting you at risk of not benefiting from the digitization of society. Different factors can be very, very clear as smartphone ownership, access to data, digital literacy, familiarity with phone use. So there's all these ones, right? So it's really multifactorial. One example in telemedicine expansion that comes to mind, a family was attending a telemedicine visit from a McDonald's parking lot because they had no reliable internet, no high-speed internet. And a lot of Canadians, a lot of North Americans still saw, especially in northern Quebec. We've talked about Nunavik being a region that's clearly underserved, but that would clearly benefit from telemedicine given the distance gap, but yet there's a significant digital divide that puts them at risk of not benefiting equitably from these technologies. And now just talking a little bit about how do we evaluate and how do we think about these innovations from a responsible innovation point of view. The quadruple aim talks about having better outcomes, lower costs, improved clinician experience, and improved patient experience as the objective to produce an intervention that leads to value-based care, right? That is able really to optimize all these objectives. The quintuple aim adds equity to the picture. Again, if the benefits are not equitably distributed, if there's a group that would definitely, or an underserved community that would definitely benefit from a specific intervention, but for one of the many reasons I mentioned earlier in terms of digital divide is not able to participate and to be included in it, we're not addressing this quintuple aim. So I think it's a good framework to think about our all the interventions that we think about, particularly in digital health and AI. With the chatbot that I mentioned earlier, some of the potential benefits here at the outcome level, while we have personalized evidence-based care, avoid unnecessary interventions, avoid delays in care. In terms of lowering costs, could potentially avoid many visits to the ED if the families are referred to the right resources or had enough information to empower them to care for their child. eventually could enable some quality virtual care. Next steps could be to triage patients into, do you need in-person care, or actually is virtual care a good option for you? At the level of clinician experience, having that human AI interaction is key. Task automation, we talked about Tide earlier, saving precious minutes when you're reviewing mundane, abundant data can really make your life better and really focus on that human interaction with your patient. At the level of family experience, certainly family empowerment and having a trustworthy resource at your fingertips. That's, I think, a clear benefit. And in terms of a framework that dives deeper into responsible innovation, it was developed by Pacifico Silva, Pascal Lehoux, Miller, and Denis here from Montreal. It's the Responsible Innovation Health Framework. And so the value domains that it proposes to consider in any health innovation that could potentially be applied at scale is population health value, the health system value, economic, organizational, and also environmental, so that we think about all the potential impacts of a given innovation early on and then adapt its design so that we really are able to optimize its value across these domains and not just focus on a single domain. We'd be missing the boat. Angeliki?
Thank you. Yeah, so just switching gears a little bit. So when we talk about the use of, sorry, have different ears. So when we talk about the use of AI in healthcare, so one of the main considerations are the ethical like the ethical implications, how we can responsibly use AI. So in that context, the WHO recently released a report as a framework for AI clinicians and researchers. So there are 6 guiding principles. Number 1 is protecting human autonomy, like humans should remain in control of healthcare systems and medical decisions. Privacy and confidentiality need to be protected. Regulatory requirements for safety, accuracy, and efficacy of any AI tool need to be satisfied. Then transparency, ensuring transparency. So transparency requires that sufficient information needs to be published or documented before the design or the deployment of any AI technology. Inclusiveness, as Esli mentioned, requires that an AI tool is designed to encourage the widest possible equitable use and access, irrespective of age, sex, gender, or other characteristics. And finally, promoting AI that is responsible and sustainable through continuous assessments of the AI models. So on that note, like Health Canada, along with FDA and the regulatory agency in the UK, they published a joint statement on the good machine learning practice for medical device development. And these guiding principles are really like in alignment with the WHO statement. So some key points, some like take-home message: pediatric medicine, it's ripe for digital innovation. The aim of our projects is for interventions that add value across the quantifiable aim objectives that Esli described earlier. Public engagement and responsible innovation are paramount to foster a fruitful human-AI interaction. So in our last slide, we put together some resources in AI in healthcare for people who are probably interested. So the government of Canada has put together an algorithmic impact assessment. So basically, this is a questionnaire that helps you assess the impact of the AI tool that you're developing. And it includes like questions about risk and mitigation strategies. And it helps you like improve areas in your machine learning design. Then we have the American Board of Artificial Intelligence in Medicine that offers review courses and like many network opportunities. And finally, the Missionary Institute here in Toronto provides a really useful course for practicing clinicians, like a certificate program for practicing clinicians who do not necessarily have a background in computer science as myself. And actually, both Esli and I and Dan, like we had attended this a couple of years ago, and it gave a really nice framework about how machine learning models are developed and validated and how we can implement this in our clinical practice or our research programs. Oops. And I think that's our last slide, or yeah, we must have one more
We had
slide.
updated the slide, but one additional resources, unfortunately didn't make it to the
Oh,
slide.
yeah.
Is a reading group with Mila that Dan has put together with some of our colleagues as well. So every 2 weeks on Tuesdays at
Yeah.
noon, there's a lunch clock reading group on different topics. We've covered reinforcement learning, NLP, AI and primary care so far. So really interesting topics. And it provides that interface between the algorithm developers and also researchers and clinicians. So it's a very fruitful collaboration. If you're interested, please feel free to reach out, and we'll put you in touch with the student who organizes the group.
Okay, and a very last note is that research in AI in healthcare is by default multidisciplinary. Like it relies on strong collaborations between clinicians and computer scientists. The clinicians are bringing in the clinical expertise that they have through their daily patient encounters. They can identify the clinical questions that need to be answered. And then you have the computer scientists or the data scientists that have the skill set that they can develop the tools that are going to answer like these questions. So on that note, like along with two other pediatricians here at the Children's, Dan, who is here, and Catherine Goody, who's a pediatric hematologist, who have put together a very informal group that aims in promoting, aiming to promote responsible use of AI in medical and surgical care of children. And our group actually is now part of a larger international effort that's called Pediatric Centers for AI in Medicine. This is led by some of the largest academic institutions in the States that lead many of the artificial intelligence advancements that we see in healthcare. And actually last year, Esli represented our group at the Global Summit in San Francisco. So it's an exciting time to be involved in this type of research. So yeah, and so on that note, we welcome any questions or comments.
From Dr. There's the Toronto Summer Course for AI for Public Health and Public Policy, Artificial Intelligence for Public Health Summer Institute that will be offered in Toronto, Ontario.
Okay. It's good to know. Oh, I didn't know that. I was not aware of that. Perfect. Please. Yeah.
So very nice talk. Really like raise the issue of evaluating impact of these sometimes very shiny looking interventions. At the end of the day, is it actually improving patients? But one thing that I did see mentioned too much, it was on one of the WHO slides, it wasn't underlooked, is accountability. I guess by analogy, I'm thinking of self-driving cars, and while I presume at some population level they might reduce the number of accidents or injuries on average, at the individual level, you're the victim of an AI accident. What's the exact, who's responsible and all? So I guess that translates to the healthcare sphere. What's the current thinking, or how does one protect against that?
So the
physician who is employing this method, or the institution ultimately assumes the responsibility.
Oh yeah, please. So basically there has to be an informed, valid consent from the patient. So this is the technology that we're going to use. Yeah, so far, for sure, what we're doing so far, in at least in our research programs, are not clinically validated tools, are not yet being used as part of standard clinical care. So everything is done as part of research. So a validated consent form is going to be part of any participation in research. But even in institutions that are using some of these tools as standard of care, a very informed and detailed consent form needs to be signed. So the patient needs to be aware that the decision that I'm going to make as your physician of what medication I'm going to give you is based on this machine learning tool. And this tool was developed using this data set. For example, it was developed using data that we have on Caucasian patients only, or data that we have on different patient populations. So there has to be a very open and transparent discussion about what are the limitations and the strengths of these artificial intelligence tools.
You make a great point. I think that also that has a couple of ramifications. I think it has the ramification of education among clinicians to be able to use those tools as they should be used. A couple of years ago, there was an interesting proposal to have almost like a food label of a model. Like this model has that many carbs, that many proteins, and it was validating is this kind of data. This is the question we're trying to answer. This is the need it's trying to fill. This is how you apply it in a responsible way, essentially, just really to bridge that gap and offer more interpretability as you're describing. And then there's also the education, the public level. What's your right, to refuse or to accept what happens to your data? To what level can you participate in this decision making? I think those are still up in the air. But one question I would ask is, once you have a gold standard algorithm that becomes actually, in radiology or pathology or very, some of those specialties where AI has made great advancements, there's algorithms that have been approved as medical devices, right? Approved by the FDA. So now the question is, if you don't use those algorithms, are you liable, right? So it can go the other way, right? So I think we really need to be aware of where we're at. The rigorous, comprehensive evaluation, both from a patient level, but also the population impact, is super important to be able to grant it approval, and then as an institution say we're going to start using it, but then also being very transparent on the front end at the interface with the families.
Those are very helpful answers. Thank you. It strikes me where I have a high level of uncertainty is I have some projects that are very intensely involved in use of machine learning and imaging of the lung, very rich data set. Something we continually struggle with is whatever you learn on to achieve whatever performance that you're happy with. That data set was from this time, 2010. Scanner technology has changed a lot, and so the features that it was learning, they still apply. And the same thing I think would probably apply to any application. You could say EHR type data sets and stuff. I can think of examples where the new illness comes along like COVID, and maybe those patterns of presentation or symptom constellations, they've never been seen before. And so how does the algorithm manage that? So it needs to be continually learning, but do we have a regulatory process, even like FDA approval? I mean, what's the expiry date on that? It's just a lot of unknowns. It's a great field to be stepping into for sure. There's just so many.
And it's very new, questions. Right? And it's really recent, despite the fact that AI has been around for a few decades. In healthcare research, it's like maybe a number of years that research is being done on that field. And so, no, like that's
valuable to so many limitations in our systems right now. It's just this.
Yeah, we need to define the framework exactly. There has to be, and that's what the WHO and Health Canada and FDA they're trying to put with these joint statements that are being published.
And at the end of the day, nothing's going to replace understanding what your problem is and posing the right questions, right? Angeliki talked a bit about some unsupervised techniques to help identify hypotheses and so on, but at the end of the day, you still need to understand what you're trying to solve as a problem, and not go for the shiniest tool because it is the shiniest, and really find the right technical tool. So
in some ways, by revealing or having me think about what the limitations might be for AI, it allows me to look in the mirror. What are am I continually updating my training? And we're not.
What's the alternative?
And so it's sort of it's formative in both ways.
And perhaps. Absolutely, and I think one way to more effectively deploy AI is perhaps at the operations aspect. Some clear, simple algorithms to predict OR time so that you have the right number of beds. You don't cancel surgeries. You don't rely on Gestalt. So these are very understandable, explainable, interpretable algorithms. Been done elsewhere, have been shown to improve operation metrics and also patient related measures. So that could be a good way to integrate more AI into our daily practices, where the risk in terms of what if you get that prediction wrong, okay, the surgery will last a bit longer, maybe you have an extra bed, but we're already doing that status quo. We're not perfect in that prediction, but you're not missing a lung cancer, you're not missing meningitis, you're not missing a devastating cancer, right? So, so maybe just think a little bit about which area you want to get involved in, and what are the balances, checks and balances in place that you should always have that human AI interaction at the end of the day. I think that's really important.
Comment from Dr. Bernatsky, who I guess clicked on the link for the summer course. Applications are closed for this year.
Oh.
So maybe 2024.
Early bird.
Thanks so much.
Any last questions? No? Okay.
Thank you.